So today the topic of discussion will be nausea and vomiting in cancer, which is also termed as the CINV, that is not cancer related nausea and vomiting, sorry for the mistake. It is chemotherapy induced nausea and vomiting. So without delay we'll move forward. So nausea and vomiting are among the most distressing and feared complication of cancer and treatment. So 70 to 80% of the patients receiving chemotherapy without prophylaxis, there is a chance that they can have nausea and vomiting in around 70 to 80 percentage, as well as a significant proportion of people who receive radiation therapy, targeted therapy or immunotherapy are also in a risk of developing nausea and vomiting as a side effect. So we know what it ultimately leads to. That can lead to the treatment interruption, and because they can just quit the treatment because of this side effect, and malnutrition and dehydration, that is one of the major complication, and poor quality of life of course, and increased hospitalization and the cost burden. So it is considered as a major determinant of treatment adherence and therapeutic outcome, of course, because when the patient is having severe side effect, the major chance is the treatment interruption that can ultimately have an effect on the treatment adherence and the therapeutic outcome. So what is nausea? So when we talk about nausea and vomiting, we have to understand there is some terms that is associated with nausea and vomiting. So first one is queasy. So queasy is the mild stomach discomfort. It's a sort of feeling, or like mild stomach discomfort that is followed by nausea. So nausea is an unpleasant sensation, or that is an urge to vomit, but the patient is, or the person is not vomiting here. Next is followed by retching. So retching is like, it is an attempt to like without expelling the gastric content. You are not actually expelling the gastric contents out, but you are having an attempt of what to tell you to vomit, and followed by the vomiting. So this is how, when we understand nausea vomiting, this is how it goes: queasy followed by nausea, followed by retching, and followed by vomiting. So what is nausea? It is, as I already mentioned, it is a subjective unpleasant sensation with urge to vomit, and this is associated with autonomic symptoms. So what is autonomic symptom? These are caused by the activation of the autonomic nervous system, especially the nausea and vomiting. Okay? So this is due to the stimulation of the sympathetic and parasympathetic nervous system. There will be some symptoms, there is some autonomic symptoms, that is like salivation, setting, like the GI related symptoms like hypersalivation, dry mouth, increased gastric secretions, then pallor, tachycardia. So these symptoms will be there. These are the autonomic symptoms. Then, what is vomiting or the emesis? It is a forceful expulsion of the gastric contents through mouth due to the coordinated reflex involving gastrointestinal tract, respiratory muscles, and the central nervous system. So, these are the three main area that we have to focus when it comes. This coordinated reflex only will be resulting in the vomiting. So what is the action of all three of these areas? So like when we talk about the respiratory muscles, the diaphragm will be moving downwards. That will create an intra-abdominal pressure. So this intra-abdominal pressure, we know that the abdominal muscles are so strong, so this can contract, this will give a compression to the, this contraction can give a compression to the stomach, and this ultimately forces the gastric contents upward, and further resulting in the forceful expulsion, or what is termed as the vomiting. And for respiratory protection, what happened? The glottis will be closed and the soft palate will be elevated, so that it will be prevents the nasal regurgitation. So these are the respiratory protection action that is happening. And it's an interesting fact is that breathing temporarily stops for some seconds, so that the respiratory protection happens here. So and the central nervous system, so we will see what is the major pathways and the especially the neurophysiology that is involved in the vomiting. So moving towards that, we know the vomiting is controlled by complex neural circuits. So in this, what is majorly involved is the vomiting center, the chemoreceptor trigger zones, the peripheral pathways, and some of the neurotransmitters. Actually, when we talk about the antiemetics, these antiemetics majorly majorly play a role in these neurotransmitters. So it's also important to understand these neurotransmitters. So these are the major complex neural circuits. So first one is the vomiting center. So the central vomiting center. So the central vomiting center, yeah, I'll be speaking regarding that. That is the central vomiting center. So the vomiting center, it is located in the medulla oblongata of the brainstem. So it is actually it's not a single anatomical structure, but it's a network of the nucleus. So it is having many structures like nucleus tractus solitaris. We will tell as NTS, dorsal motor, and the reticular formation. So these are the structures form the central pattern, or like these form the generator of the vomiting. So what happens is here the function is the vomiting center. It serves as the final integrator. It is the coordination site for the vomiting reflex. So these it receives. This is actually the coordination site. So actually it is receiving the impulses from several pathways. It can be from the chemoreceptor trigger zone, from the gastrointestinal tract, from the vestibular apparatus, from the higher cortical centers, and other receptors like maybe the pharyngeal and the visceral sensory receptors. So what happens, I'll just take an example of the chemoreceptor trigger zones. So the chemoreceptor trigger zones, it is located in the area postrema. So this area postrema, it is in, near to the medulla oblongata, that is in the floor of the fourth ventricle. So we know the CSF flow and the blood brain barrier outside, all these things, it is so much sensitive to the circulatory toxins and the drugs. So since it is very near to the ventricles, so it can easily detect the flow of any chemicals or toxins. So this is majorly the that is the reason it is located outside. The blood brain barrier is located outside. So yeah, so this is the chemoreceptor trigger zone. So this chemoreceptor trigger zone is very much sensitive to the circulating toxins and the drugs. So it is having also some kind of receptors. So what happens actually when that is in the chemoreceptor trigger zone is, think like an patient is receiving chemotherapy. So the chemotherapy actually it will damages the normal cells. For example, think that the patient's intestinal mucosa is getting damaged. So in the intestine there is some specialized cells called the enterochromaffin cells. This enterochromaffin cells is getting stimulated, and this will be ultimately releasing the serotonin. So this serotonin, I was telling, there is some important neurotransmitters involved. So the serotonin or the 5-HT3 is also one of the important neurotransmitters, and because of the damage to the intestinal mucosa, this enterochromaffin cells will be releasing the serotonin. The serotonin will be stimulating to produce the 5-HT receptors on the this it will stimulate the 5-HT3 receptors on the vagal afferent nerves. So this signals reaches the where the vomiting center. This is how the vomiting center is getting activated. So ultimately what happens from the from the intestinal mucosa, it is moving towards through the stimulation of the serotonin, moving towards the vagal afferent nerves, and then ultimately it will be resulting in the stimulation of the vomiting center activation. So ultimately the vomiting center activation of the vomiting center is the major area, or it is the key area where the coordination site of the vomiting reflex. So and that is the vomiting center. So the vomiting center it receives all the input. It can be from the chemoreceptor trigger zones, it can be from the gastrointestinal tract, it can be from the vestibular system, it can be from the higher cortical centers also. So other than that, there is peripheral pathway, like as I told, chemotherapy and radiation causes mucosal injury, serotonin release when it damages like the intestines. The enterochromaffin cell stimulation, that is another pathway which can ultimately contact with the, or that has a coordination with the vomiting centers. Okay. So that is a major thing that you have to understand in this. Like there is one of the major areas is a central vomiting pathway, that is the vomiting center is the major area, and the chemoreceptor trigger zones, which is located in the area postrema, and this is actually very much sensitive to the circulating toxins and drugs, and the peripheral pathways that can be through the the serotonin, the receptors, that is from the intestinal or the mucosal injury, and there are some other receptors also that we will be discussing further. So the peripheral pathways we have discussed. Now moving towards the etiology, there are many etiologies when it comes to the cancer. The chemotherapy, especially the highly emetogenic drugs like cisplatin, carboplatin, cyclophosphamide, there are many drugs, and the drugs are actually classified based on how emetogenic the drug is. So the chemotherapy emetogenic classification is actually based on highly emetogenic drugs. So these are greater than or 90 percentage. The patient can have vomiting if the patient is not given with anti-emetic drugs. Like think a patient is receiving chemotherapy and the patient is not received anti-emetic drugs, and if this specific drug is given or the drugs is given, the patient can have more greater than or 90%, the patient is having a chance of developing the nausea or vomiting. That classification is termed as the highly emetogenic drugs, followed by the moderately emetogenic drugs. So the moderately emetogenic is like the person is having chance 30 to 90 percentage, and low is from 10 to 30 percentage, and minimal risk is less than 10 percentage. So there are some drugs, like I'll tell some of the examples, like highly emetogenic drugs are like cisplatin, dasacarbocyne, cyclophosphamide, and the moderately in this carboplatin, oxaliplatin will be coming, and the low emetogenic drugs paclitaxels, etoposide, and the minimal like vincristine, bleomycin, these drugs will be coming. So these are some of the examples. So I was just telling like how when we talk about the chemotherapy, it's not like some of the drugs are just highly emetogenic. There is some classification for that also. So next is the radiation therapy. Especially the previous pathway which I told, how the serotonin 5-HT3 receptor is getting stimulated when the mucosal injury is happening in the intestine, which stimulate the enterochromaffin cells. That is one of the pathways. So in the same way, radiation therapy, especially in the abdominal or the cranial, in the cranial, when it can directly stimulate the vomiting center. So these sort of radiation therapy, and side effect of other cancer medications, like it can be the opioids and the targeted therapies, and GI obstruction or constipation. We know how it's very clearly understandable how GI obstruction and constipation can result in the vomiting and the brain metastasis and increased intracranial pressure. So these are also actually it stimulate the vomiting center or the chemoreceptor triggers on because of the pressure and in the brain metastasis and electrolyte imbalances. Any sort of hypercalcemia and hyponatremia because of the therapy or because of the tumor itself, like because of the paraneoplastic syndrome, all these things can further result in the nausea and vomiting because of the cancer. Now talking regarding the chemotherapy induced nausea vomiting, there is some classification for that vomiting based on the time period. So this is basically the acute, that is occurs within 24 hours after the chemotherapy. When it comes to delayed, it develops after 24 hours up to 2 to 7 days, and post chemotherapy. Anticipatory, like the person or the patient will be triggered by sight, smells or thoughts. Even thinking of the chemotherapy, the person can get nausea or vomiting. And the breakthrough, even after giving the prophylactic anti-emetic treatment, even then they will be having the nausea and vomiting. And the refractory is like it is still continuous despite of the optimal anti-emetic therapy. And there is something other called chronic chemotherapy induced nausea and vomiting, that it persists for a long time, even after the treatment completion also for a very long time it persists. That is the chronic the nausea and vomiting of chemotherapy. So this is the types or the classification of the CINV. So what is the standard anti-emetic regimen? There are of course many anti-emetic regimens and many combination that is given to the patient prophylactically before the chemotherapy or the radiotherapy. And here if you can see, as the drugs are classified based on how emetogenic the drug is, on that basis the chemotherapeutic drugs is also classified. So the first one, as you can see here, highly emetogenic chemotherapy, that is as I told, greater than 90% of there is chance of getting, a person is having nausea and vomiting if the patient or the person has not received antiemetic drugs. So in this comes is the aprepitant, fosaprepitant, and the 5-HT3 receptor antagonist like ondansetron. And so when you see this, you can see there are some important neurotransmitters like 5-HT3 receptors, which is blocking that receptors is ondansetron and palinestrone. So based on that, as specific action the drug will be given, and it will be given as combination like along with steroids, along with the proton pump inhibitors, and along with anxiolytic drugs also. Like if you can see here, a corticosteroid is also is there, and the anxiolytic optional drugs is also present. For the moderately emetogenic drugs like ondansetron, palinestrone is applicable, and corticosteroid, and minimal it may receive or may or may not can have the require routine antiemetic. So basically, understanding antiemetic regimens, understand the receptor that is actually working on. So in the 5-HT3 receptor antagonist ondansetron, the cetron class of drugs comes, and the NK, that is the serotonin, and the NK, that is the neurokinin receptor antagonist, the aprepitant and fosaprepitant drugs is coming. So next is the clinical manifestations. As I already mentioned, the steps how the pathway of the vomiting can happen. Like it starts from a feeling of sensation like queasy. It's not important that everybody should go through all these phases, but queasy, mild stomach discomfort followed by nausea and unpleasant sensation, and retching and attempt to vomit, where actually the vomiting doesn't happen, followed by the vomiting. Other than that, anorexia, because of the persistent nausea, the person may have anorexia, excessive salivation, because I already mentioned the autonomic symptom, and the fatigue, the weakness and the tiredness because of the complications, like they may go into dehydration, electrolyte imbalances. So that also can further result in the weakness, tiredness, and as I told, dehydration. So what is the important assessment and evaluation that comes? Of course, patient history. So if it is a chronic CINV or it's an anticipatory CINV, it's very important to understand what is the past chemotherapy, what is the drugs the patient was taking, as well as the antiemetics that has been given, and any other medical associated conditions like any intestinal obstruction or anything else. As is the frequency and severity, it's very much important to understand when it started and what is the duration, what is the intensity of the nausea and vomiting, as well as to identify the triggers like any specific chemotherapy drugs, any sights and smells, and any complications like dehydration, electrolyte imbalances is very much important to be quickly understood and to be treated, and the patient impact, as well as there are many different tools that is available to see the nausea and vomiting scales, and the patient diaries, how often the patient is having nausea and vomiting. What is the pharmacological management? Like as we have already discussed, it is based on the receptors, it is the action that is coming. Like when it comes to the neurokinin receptors, that is aprepitant class, and the 5-HT3 receptors, that is ondansetron, palinestrone. The dopamine antagonist, it blocks the dopamine receptors, that is the metoclopramide, and the corticosteroids and the benzodiazepines and other anxiolytics are optional. So the known pharmacological management, some of the things that we can apply is like dietary modification. Of course, this is something that we commonly use in our daily life, providing very small frequent meals, avoiding very excessive oily, spicy, and strong smelling food, encourage intake of cold and room temperature foods, and promote adequate hydration. Behavioral and psychological interventions like relaxation techniques, guided imagery, and deep breathing exercises, CBT, like when it comes to patient having refractory CINV and or anticipatory CINV, and the distraction techniques, and the other like acupuncture are also one very interesting, and the upcoming methods of treating this, like there is something called the Naguan point. When you keep 3 finger breadth above the wrist, sorry, below the wrist crease, so that point is actually termed as a new Guan point. So if you give a very slight pressure over there, that can ultimately there is a reduction in the nausea and vomiting. This should be done with supervision from the qualified personals. So this acupressure, acupuncture, aromatherapy, massage therapies is a very good upcoming methods of treating this sort of nausea and vomiting. Environmental modifications like fresh, well ventilated rooms with free of all smells of all drugs and unpleasant odors, and the patient educations like what is important dietary precautions and what is the important nausea symptoms to be treated and what is the major complications and the side effect of those complications should be discussed with the patient as early as possible. So complications, we know what is the major complications like dehydration, the malnutrition, electrolyte imbalances, aspiration pneumonia, especially when the patient is very weak and like the patient cannot handle himself or herself, and this is one of the major complications, that is aspiration pneumonia, which should be very much as a nurse it's very much important to be checked often. And environmental modifications, maintain fresh and well ventilated surroundings. So this is the complications of CINV. So as nurses, nursing management comes, what is the important the severity, the frequency, duration is very much important to understand. The hydration status, electrolyte imbalances, the triggering factors, the nutritional status, and when it comes to medication administration, the correct dose at the correct time should be administered, and the side effect, the effectiveness should be checked. And the medication adherence is one of the important thing that should be checked, and that should be properly maintained in this sort of patient. And the comfort and the supportive care as well as the education is also an important aspect. So nausea and vomiting, it's not a very simple topic or a very simple area. You can read more on that. It's just a gist of the things which basically what you have to understand when it comes to the oncology or when it comes to the cancer. So in which all pathway it affect, what are the classification of the emetogenic drugs, and what is the major antiemetic drugs that is given, and what is the major treatment modality that should be followed in this sort of patients. So some of the interesting factors when it comes to the patient related risk factors in the CINV, if I tell, like female gender, they're having a greater sensitivity to the vomiting pathways because of their hormone, that is estrogen and progesterone, that has an increase in the stimulation of the serotonin. So that is another important point that we can keep in the mind. And as younger the age is, there is more active neurotransmitter receptors, and the patient can also have higher vestibular sensitivity. So these also can result in the more nausea and vomiting. Like if a person is having a history of motion sickness, like most of us might have experienced or might be having currently the motion sickness, so that also have a because they have a hypersensitive vestibular system. So ultimately what happens, they are already used to it, that they can have a high chance of nausea and vomiting. Anxiety, another reason, it stimulates the autonomic system, and it activates the release of the serotonin. So that is another reason why we prefer anxiolytic as a combination along with these drugs. And low alcohol consumption, so we know how the chemotherapy trigger zone works. So it is actually very sensitive to the drugs, and like if a person is continuously taking alcohol, and they are actually they are having a tolerance to the toxins. So when a person is low alcoholic, doesn't mean that we should go and consume alcohol, it's not the meaning. But when a person is having a low alcohol consumption, the partial tolerance to the toxins will be present, so that there is a chance of they can have more nausea and vomiting when compared with chronic alcoholics and previous poor control of the CINV, which means that already the patient has received multiple cycles of chemotherapy with antiemetic, but even still he or she is not able to control the nausea and vomiting. So the brain develops a conditioned response. The proper control of the first chemo is very much important. It may develop to chronic or anticipatory vomiting. So as nurses, it is very important. We cannot think that it's very common with a chemotherapeutic drug. It's not like that. It's very much important to understand and manage the anticipatory vomiting or the first chemo. Proper control of the first chemo vomiting is very much important, so that the patient will not be developing further sort of the anticipatory vomiting. So these are some of the interesting points that you keep in mind, and you can read more on that. And if anyone wish to have the PPT, can just kindly mail me.